Good afternoon, everyone, and welcome to our webinar for today. We're going to be talking about self-measured blood pressure and why timing matters and other practical tips. My name is Brenda Jenkins. I am Senior Program Administrator at Health Center Advisors, and I lead our self-measured blood pressure SIP here. And today we have the pleasure of having the American Medical Association joining us as the key speaker. Today we have Linda Murakami. She is the Senior Program Manager in Practice Facilitation and Quality and Improving Health Outcomes for the American Medical Association. She is a Senior Program Manager for Practice Facilitation and Quality in the Department of Improving Health Outcomes at the American Medical Association. In this role, she provides leadership and technical expertise to primary care teams by conducting data-driven quality improvement coaching. Ms. Murakami has directed quality improvement programs in the ambulatory and home health settings. She has a clinical background as a registered nurse with a focus on medical and oncology patient population. Please welcome Linda.
Thanks, and thank you everyone for taking time for this webinar today and for allowing me to talk to you. So let's, and this is, you know, I have no disclosures. And these are our objectives for today. I'm going to explain the benefits of self-measured blood pressure, also known as SMBP, on improving blood pressure control, and evaluate current self-measured blood pressure programs, your current programs based on best practices and guideline recommendations. I've had a few conversations with some of the health-centric team who've provided me with details of the work you guys are doing on this project. I understand that you've had information sessions on self-measured blood pressure already and are really deep into this work. So in this presentation, there is likely information that you're already aware of. My presentation here will hopefully give you some additional tips based on the guidelines, best practices, and evidence from the literature. So I hope you're able to compare what you're currently doing with this information and perform like a gap analysis that may help you improve the ability to reach your goals.
All right, then give us a call. I'll try and book you something for tomorrow. Find out what time you can come tomorrow, what time you can get a ride tomorrow.
And there we go. Okay. Just a little issue advancing the slides. I apologize for that. Okay, so one of the main reasons to use self-measured blood pressure is to make sure we accurately diagnose patients with hypertension. So the United States Preventative Services Task Force has recommended out-of-office measurements for confirming a diagnosis of hypertension since 2015. Then in 2017, the American College of Cardiologists and the American Heart Association hypertension guidelines also recommended out-of-office readings to confirm a diagnosis of hypertension. So 24-hour ambulatory blood pressure, also known as ABPM, is the preferred method, but it can be difficult to obtain those due to availability and cost. You know, it often requires like a referral to cardiology to get that done. Most primary care practices don't have the device or the means to do that. So self-measured blood pressure has been found to be a more convenient method to confirm hypertension with out-of-office measurements, and based on the evidence is comparable to a 24-hour ABPM. Self-measured blood pressure is convenient for your patients. I know within this project you're able to give devices to your patients for free, but when outside this project, self-measured blood pressure is a cost-effective means for patients to perform out-of-office blood pressure measurement. And always remember to have your patients use a validated device. So self-measured blood pressure helps you identify white coat hypertension, which occurs when you have blood pressures that are high in the office but show no hypertension outside of the clinical setting. You can see screening for white coat hypertension is recommended for patients not being treated for hypertension if they have a systolic blood pressure of greater than or equal to 130 millimeters of mercury or less than 160 millimeters of mercury. or they have a diastolic blood pressure of greater than or equal to 80 but less than 100 millimeters of mercury. So it's one or the other. You know, it can be both, but if systolic is high and diastolic is lower, we still are going to take and react to those higher numbers. You want to screen for those who are on multiple meds for hypertension, but their blood pressure might still run high within 10 millimeters of mercury above goal. This last example will be your patient who's compliant with meds and diet, but isn't quite reaching control yet. So white coat is usually considered clinically significant when your systolic and diastolic blood pressures are greater than 20 over 10 millimeters of mercury or higher than home or, 24-hour ABPM systolic and diastolic blood pressures. So the prevalence of white coat hypertension is higher with increasing age, more often in female versus male sex, and smoking versus non-smoking versus current smoking status, and then also a routine office blood pressure measurement of by a clinician rather than unattended blood pressure measurement. And when we say in the clinical setting unattended blood pressure measurements, that refers to those who have the capability of performing automated office blood pressure using a device that can, measure the patient's blood pressure and automatically repeat those blood pressures without somebody in the room, so that eliminates that white coat anxiety for the patient. So mass hypertension.
Linda, excuse me just for a moment. I'm going to ask if you are on the line, if you could mute your line while the speaker is talking, because we're getting some feedback. Thank you.
All right. Thank you. And mass hypertension is identified in people with normal blood pressure in the clinical setting, but high blood pressure outside the office. And the prevalence of mass hypertension varies from about 10 to 26%, with a mean of 13% in population-based surveys, and from 14 to 30% in normotensive clinic populations. So those are people who do not have high blood pressure. They still, can experience mass hypertension. So mass hypertension is associated with cardiovascular disease and all-cause mortality risk twice as high as patients who are normotensive. These individuals, and they have a risk range similar to that of patients with sustained hypertension, which makes sense because these patients are walking around with high blood pressure and they don't even know it because they're taking their blood pressures in the clinical, at the doctor's office, and everything seems fine. So it's usually often not until there are signs of target organ damage that mass hypertension is identified. And that's why it's compared to sustained hypertension, where, their blood pressure is also not in control.
We're at school now.
So the table on the left compares blood pressure between the clinic and home readings. When in the clinic and the blood pressure is 120 over 80, you would expect the blood pressure at home to be the same as is for the result of 130 over 80 millimeters of mercury. But the changes start when the blood pressures in the clinical setting in the office are 140 over 90. It's here where the evidence shows the comparable blood pressure at home would be 135 over 85, and then a larger difference is expected for office blood pressures of 160 over 100, that it should be 145 over 90 at home. So these numbers are, from the current ACC, AHA hypertension guidelines, but are based on studies comparing home and office blood pressure measurements.
And then they go home. But
Excuse me, I'm going to interrupt again. There's somebody who's
hypertensive.
through. I'm going to ask you if you could please put yourself on mute and respect the speaker, because we're hearing your conversation and it's very distracting.
Phenomenon. So it seems like they're elevated in clinic.
It's still 145 over 90.
I think it's two different.
Oh.
Okay, so I'll just keep talking over them. How's that? Let's see what we can do. Okay, so these numbers so from the guidelines. So it's felt that the difference happens because the patients are taking their blood pressures at home. They're in a more relaxed setting in their own environment. And then the table on the right shows some differentiation of hypertension into the several clinical categories based on the location of blood pressure measurement. So where it says ABPM, that's, you know, the 24-hour automated blood pressure measurements, just so you're aware of the headings. So reiterating the categorizations, white coat hypertension is characterized by elevated office blood pressure, but normal readings when measured outside the office with either ABPM or home blood pressure. Chest hypertension is characterized by office readings suggesting normal blood pressure, but the out-of-office readings that are consistently above normal. So in sustained hypertension, you can see the blood pressure readings are elevated in both the office and the out-of-office settings. Every once in a while, it takes a few hits to move those slides. So here's how self-measured blood pressure improves the maintenance of blood pressure. In 2015, there was an Australian expert consensus that published home blood pressure measurement can help assess the antihypertensive treatments that's being used. The study found that therapy guided by home blood pressure measurement compared to usual care based on office blood pressures led to significantly more patients achieving blood pressure control and larger blood pressure reductions. So when we talk about assessing control across a 24-hour period, self-measured blood pressure offers the opportunity to assess treatment effects at different times of the day and over extended periods of time. The convenience of self-measured blood pressure for patients is particularly helpful for repeated measurements. Treatment decisions are based on the average of the series of blood pressure readings taken. But patients taking their blood pressure should be informed that blood pressure may vary between measurements and not to be alarmed with high or low results on a single occasion. Only be concerned if the results persist or associated with clinical symptoms like, chest pain or shortness of breath while they're taking their blood pressure readings. So in one study, they additionally reported that compared with clinic blood pressure measurements, both systolic and diastolic blood pressure improved with home blood pressure monitoring. Plus, home blood pressure monitoring was associated with more frequent medication reductions, and the relative risk of therapeutic inertia was reduced by 18%. And therapeutic inertia occurs when there's a high blood pressure that is not acted upon. They didn't order any meds or any treatment or ask for any follow-up for the patient. So self-measured blood pressure can increase patient engagement because it's getting them involved in their care. It can be used to monitor the effects of any changes to the treatment regimen, such as increasing med doses, adding medications, or even when the patient implements lifestyle changes such as diet and exercise. Patients and providers benefit from seeing the direct effects of these interventions through the self-measured blood pressure readings. And when I spoke about identifying white coat hypertension earlier, it suggested to use self-measured blood pressure to determine if treatment-resistant hypertension is present for patients with difficult to control blood pressures. So there was a study done in 2011 with over 8,000 patients, and it was found that 37% of those patients thought to have treatment-resistant hypertension actually had white coat hypertension after having out-of-office blood pressure monitoring performed. So this is extremely important because misdiagnosis and could lead to overtreatment with potential for patient harm, where we become concerned, especially in our elderly population, where they can tolerate, they have less tolerance for that. So with recommendations, the guidelines recommend the patient take their blood pressure 2 times a day, when they wake up and before they go to bed. And with each time, they're going to take 2 readings, 1 minute apart, for each of these sessions. So you're going to get 4 readings a day, 4 measurements a day. So we want the patient to take their blood pressure before taking their antihypertensive medications so that you can assess if the patient's medications are covering them for the 24-hour period. So some drugs like ACE inhibitors and the ARBs, the angiotensin receptor blockers, they only cover you for 24 hours. So you want to make sure that they have enough of a dose to cover them until the next dose. So also taking it in the morning, the blood pressure in the morning may identify nighttime hypertension or the morning surge. Morning hypertension can be classified as like a non-dipper or riser, which is nocturnal hypertension. It's characterized by persistent high blood pressure from nighttime to morning and is associated with increased risk to target organs and cardiovascular events. Patients doing like 24-hour ABPM who can have their blood pressures measured while they're asleep, having a sleep hypertension, so high blood pressures while you're sleeping, actually is the #1 predictor of mortality. So morning hypertension also can be classified as the morning surge. It's associated with extreme blood pressure dipping at nighttime and increases your risk for stroke. The risk of a major cardiovascular event was significantly higher in treated patients with morning systolic home blood pressures of greater than or equal to 145 millimeters of mercury. And then the morning systolic home blood pressure associated with the minimal risk, where this is the blood pressure in the studies that was found to have minimal cardiovascular effects, is the patient whose blood pressure is 124 millimeters of mercury systolic. And there was a recent study published in the European Society of Cardiology in October. It was in some of the news, local and national news. The study talked about patients having better outcomes if they take their blood pressure medications before bedtime. So these examples, would help with that nighttime hypertension and morning surges, and that's the rationale for taking your blood pressure medicine at bedtime. And again, that's kind of a provider call, but they found if, one or more medications taken at bedtime, they may be taking other meds during the day, like in the morning, but if they take one or more of their meds at night, it really decreases the risk of a cardiovascular event, they said by up to 45%. So here's some recommendations on how often to measure blood pressure at home. It's preferred that you get at least 7 full days of readings, which would equal 28 readings if it's done as suggested in the previous slide. They find that making treatment decisions based on 3 days of readings, which is a total of 12 actual measurements, is sufficient, especially if using these to gauge control prior to a provider appointment. We suggest telling the patients to take it for the full 7 days in hopes that you get a good 3 days worth of readings to work with. Patients are often asked to take measurements for longer periods of time. This is especially common when medications are added or a therapy is escalated. Usually patients will see effects of medication changes within the first few days, but will have a very good idea of its optimal effects with 2 weeks worth of readings. So you can see the marker for uncontrolled blood pressure at home is greater than or equal to 135/85. The guidelines recommend that blood pressure readings be averaged. So for 1 week or 2 weeks of readings, all systolic readings should be averaged and the diastolic readings averaged separately. This average result is what you would be documenting in your EHR and use that reading result to manage blood pressure. So it's known that the number of readings that should be averaged to give the maximal prediction of cardiovascular risk is in accordance with a study that was done in Japan that showed a progressive increase in the ability of home blood pressure readings to predict stroke and cardiovascular events by increasing the number of measurements. So at this point in the project, what I'm going to state next won't apply to you guys, but for patients taking their blood pressure at home for the very first time, many experts recommend excluding the first day of readings. So it's thought the patient may not take those first readings as accurately as they will the subsequent readings. They think they might likely be more nervous, for the first time in spite of being at home. So I'll personally say that this is a recommendation that we mention to our partners, but we don't always reinforce it, especially if good training was done and the patients were adequately performing, return demonstration before leaving the clinic or the training setting. So again, I'm hoping everybody's noticing that these slides continue to use a threshold of 135/85 for home blood pressure readings to be categorized as hypertensive. But anyway, you can see I posted up here the CDC Millions Hearts treatment protocol. On the right-hand side, it's my understanding that this is what is recommended for your study, the protocol used in your study. So, whether you're following this protocol or another treatment protocol or algorithm, again, I'm stressing the marker of 135/85 millimeters of mercury is what needs to be acted upon when treating the patients. So the protocol for Million Hearts was published in 2015, so it's just a few years old, but the 2017 ACC/AHA guidelines have other recommendations when suggesting medications for the treatment of high blood pressure. Use of 2 first-line agents of different classes can be used either as separate agents or in a fixed-dose combination drug. Fixed-dose combinations are found to increase patient adherence to medication therapy, requiring them to take 1 pill instead of 2 or 3 pills. And we know that there's different insurance companies provide different coverage for the medications. So in some instances, we've seen the combination drug might cost more than the 2 separate medications. It is a barrier, but we just kind of need to work through it. But we've worked with many organizations that include federally qualified health centers, and even their 340B pharmacies have been very accommodating in ordering the single pill combination drugs that we've suggested based on guidelines for their patient populations. We list chlorthalidone here. It's a thiazide-like diuretic. It lasts in your system for 24 to 36 hours and allows for better coverage. It's preferred over hydrochlorothiazide, which is an extremely common diuretic, but chlorthalidone's longer coverage makes it superior to the shorter-acting hydrochlorothiazide, which is intended to cover a patient for 24 hours. But most thinking is that it actually covers the patient for less, and many actually order that drug, this is the hydrochlorothiazide, BID, or twice a day. So here's the drug classes that are used for patients with hypertension. The selection of drugs may change based on comorbidities or clinical indicators that the patients have. So, while there's a protocol for selecting meds, we still are customizing selections based on the patient. So you have diuretics, calcium channel blockers, ACE inhibitors, and angiotensin receptor blockers, also referred to as ARBs. The African American patient population, it's recommended that those patients start with calcium channel blockers and or thiazide-like diuretics. Providers probably know, but I need to feel the need to mention that you don't use both an ACE and an ARB, but one or the other. And then most patients are going to need more than 1 drug to control their blood pressure. So current evidence actually supports combination therapy instead of monotherapy. I got more on that in the next slide.
To achieve control.
So, there's clinical evidence that the overwhelming majority of persons with blood pressure sufficiently elevated to warrant pharmacological therapy will be best treated initially with 2 agents. So most patients with hypertension require multiple agents for their control. Those with higher blood pressures are at greater risk, and more rapid titration of antihypertensive medications begin to be recommended in these patients whose blood pressure is greater than 20 millimeters of mercury systolic and 10 diastolic above the target. Combination therapy shows greater blood pressure lowering effect, and single pill combinations show better adherence to therapy, which I had mentioned earlier. Using dosing of multiple meds that is half the standard of the usual dose has also been found to have less side effects because patients tend to see an increase in side effects with the higher and max doses of a single drug. So using a lower dose eliminates some of those problems. There was a double-blind study, randomized control trial, done looking at untreated patients with blood pressures greater than or equal to 150/90. And the study found that initial combination therapy for hypertension achieved target blood pressures in twice as many participants as initial monotherapy. So on average, 40% of patients put on monotherapy, achieve blood pressure control, but greater than 70% on combination therapy reach blood pressure control. So home systolic blood pressures for patients in the study on a combination therapy were like below 135 millimeters of mercury for the entire study. So if they put them on a double, two drugs or a combination therapy for the entire length of their study, which went through 3 phases, all of those patients had a blood pressure less than 135 or less than 135 millimeters of mercury systolics, and that's pretty incredible, keeping them in control for the entire time. Where the others put on one drug, and no matter what it was, ran higher, usually above 140 systolic. So that's why it's these combination drugs are really making a difference. So here's a graphic I pulled out. It's based on the JNC7 guideline, where 140/90 is the target for in-office blood pressure control. So this figure, it shows a strategy for those already on treatment of hypertension based on office blood pressure, home blood pressure, and 24-hour ABP as a recommendation. So among the individuals with office blood pressures greater than or equal to 130/80 millimeters of mercury, home blood pressure monitoring should be conducted to exclude the white coat hypertension. Individuals who are diagnosed with uncontrolled hypertension, if their home blood pressures are greater than 135/85, right? Okay. If white coat uncontrolled hypertension is considered, or there's evidence of target organ damage among the individuals with home blood pressure less than 135/85, they do suggest covering it with 24-hour ambulatory blood pressure monitoring, because we want to verify and confirm that information. But individuals who are diagnosed with controlled blood pressure, if the ABPM is less than 130/80 millimeters of mercury in 24 hours. And for the detection of masked uncontrolled hypertension, home blood pressure monitoring may also be performed in these individuals who are being treated for hypertension, who have an office blood pressure of less than 130/80, if the baseline cardiovascular risk is high. So if they've done, say, their 10-year ASCVD risk score, things like that, those are the factors to try and identify that masked hypertension. Sorry, every time I delay it, I can't move the slides, but then eventually happens. Okay, so just a couple additional things and reminders on home blood pressure measurement. Remember that daily readings are preferred when a measurement period is requested. It's helpful to gauge control by taking blood pressures for 1 week prior to a clinic appointment, as well as for 2 weeks following blood pressure medication changes. And for maintenance of blood pressure after the patients reach control, it's recommended by experts to take blood pressures, 2 or 3 times a week, just kind of random opportunities to gauge whether they're maintaining their control. So self-measured blood pressure works to improve control, even when it's just used by itself. But and the evidence supports that, but there's even stronger evidence telling us that when self-measured blood pressure is combined with additional support, it can be even more effective in improving blood pressure control. So additional support includes like counseling, phone calls, patient education about their hypertension and their meds, or even communicating online through the patient portal regarding their blood pressure results and, providing some guidance to them. These actions help that self-measured blood pressure work even better. So what you guys are doing in your project is ideal because you guys are communicating directly in real time with your patients using self-measured blood pressure. And self-monitoring was associated with reduced clinical systolic blood pressures compared to the usual care at 12 months, on average of 3.2 millimeters of mercury. It's strongly influenced by the intensity of co-interventions, ranging from minimal effect with just doing self-measured blood pressure and like no interaction with anyone else. And on average, though, with the additional support, the reduction increased by 6 millimeters of mercury. And the range went from 3.2 to 9 millimeters of mercury. So it's pretty impactful if you get a 9 millimeter mercury reduction in blood pressure, you know, just because we've had that interaction with that additional support. So it can definitely make a difference for your patients between being in control and uncontrolled. I just have this slide up here. There's upcoming CPT codes for self-measured blood pressure that are going to be in effect in January. This is just a preview, and I know you guys are going to have an upcoming, you know, information session on this, so we won't dwell on it, but it's something that you can peek at in the meantime. So that's all I've got. So if you guys have questions, you guys can open the line back up if anyone has questions. And here's my contact information additionally, if you don't have questions now.
I do. Come on. Thank you very much, Linda. This is Brenda again. I appreciate that information. I'm going to give a brief update on our pilot, and then we're going to open it up again to questions at the end. So for those of you who are not familiar, Health Centric Advisors was provided a grant from the Centers for Medicare and Medicaid to do a 7-month pilot project on self-measured blood pressure. It was the only contract in the country. We are engaging about 150 patients with uncontrolled hypertension, which is defined as equal to or greater than 140/90. About 40% of the population that we're engaging needs to come from a disparate or vulnerable population. All of the patients that are enrolled are receiving a free Omron Series 10 wireless Bluetooth monitor, and they're being educated, as well as the practice being educated on proper technique for blood pressure measurement, and practices will be having access and have currently access to real-time blood pressure measurements that are being done, so that between visits they're able to see and make changes to the treatment plan. We also have default and customizable alerts when blood pressure readings are too high or too low. And at the end of this pilot, we will be creating a national change package that will be rolled out across the country. We've partnered locally with a number of different organizations and also nationally with the American Heart Association, the American Medical Association, the Million Hearts folks, the American College of Cardiology, and the Mended Hearts organization. The thing that is unique about this program is that we have built an API or application program interface, which is a blood pressure portal. When the patient takes their blood pressure readings at home through the Omron cuff, that data is automatically transferred to the Omron database, and then within minutes it is sent to our portal, so that the practices have real-time access to those readings. And again, we have defaults set for a high and low reading so that if the patient blood pressure is higher than, say, 160 over 100, they will get a text message alert, and the practice will get an email alert. We have some new portal features that we have created. We have now a customizable panel view so that you can see if you have multiple people in your practice, you can take a look at more than one physician's patients at a time, if that's how you choose to do so. These alerts are customizable as are the actions. So we have default and customizable actions. If you get an alert and you decide you want to call the patient and make a medication change, you can multiple select whatever actions you are taking. We have critically high and critically low blood pressure alerts. We are adding in the purple, you'll see these are things that are coming soon, a high and a low pulse reading as well. We have the ability to average weekly readings and put those on a graphic display when you're looking at your reports. We also are building combination reports so you can see the readings, the alerts, and the actions all in one place. That is coming soon as well. And we've recently created some icons to identify if the patient is on antihypertensive medications or anticoagulation medications, and if the patient has atrial fibrillation. And this will be important when we're looking at those high and low alerts for the pulse rates. So some early results that we have to share on this pilot. We're very excited that 59% of the patients that are enrolled in this pilot are already in control. We have 100% patient engagement with self-measurement, which means that 100% of our patients are taking their readings at home. I will say that was at 92%, but because we have also alerts built into the system, if the patient goes 72 hours without initiating a reading, they will be receiving an alert telling them that it's been 72 hours, please take your blood pressure. Also, what happens is sometimes the practice will outreach because they'll see that there's no reading for that patient and remind the patient to go ahead and take their reading. And so now we're back up to 100%. And of the patients that have been recruited or enrolled in the program, they're averaging about 10 times a week that they are taking their blood pressure, which is exciting to see. So as I mentioned, we do have the alert system built in, and to date, the actions that have been documented in the portal, we've had 21 calls to patients, 14 medication changes, 6 messages to patients through the medical record, and then 1 appointment scheduled for the patient. So all of these opportunities for touches with the patient have really added to increased patient engagement and to that 59%, I believe, that's now in control. This is a graphic display of the average systolic and diastolic readings of the patients that are engaged in the pilot from week 1, 2, 3, and 4, and you can see that nice trending downward, so we're happy to see that. Hopefully we'll continue to build on those blood pressure readings. And these are graphic displays that you can also get in the portal for your patients as well. So I just want to share a couple of examples of patients that have improved through that in-between visit data access for the providers. We had a patient who came in, was uncontrolled at first. They were in the program, were under control because they got uncontrolled because they stopped taking their meds. They received an alert. The practice received an alert. They called to the patient to find out what was going on, and the patient had admitted that they had stopped taking their medications because they didn't think they needed it anymore because they were in control. They resumed taking their medications, and now they're back under the 140 over 90. We had another patient who was having multiple alerts all the time because their blood pressure was extremely high. There were a number of calls made, medication changes, and now that person is in control as well. So this is what we ultimately want to see be a result from having this access to the data. So far it is panning out. We are certainly open to recommendations and any additions we can add either to the portal or to the program itself. So now we'll open it up again to see if anyone has any questions. You can certainly type them into the chat. Allison, if you could unmute all the lines as well.
The non-compliant.
Are there any questions that people would like to ask of either Linda or myself? Linda, I have a question. This is Brenda. Typically, when we think about complications from hypertension, what, in your opinion, would you say would be the first system that we would be concerned about in terms of hypertension? We all know that it can lead to chronic kidney disease, but well before that, what would your concern be?
I think, I mean, it's just the stressor of the high blood pressure on the cardiovascular system, the tensions causing on your arteries and on your heart, and things like that. So, kidneys being affected might actually be, sort of a later effect that we might see on some patient populations. So, sometimes our first sign, is a TIA or, a stroke. For some of these patients, just because it's blood pressure and high blood pressure related. There's some ad council things that we worked on with the American Heart Association, where you can see these patients who are real patients doing these ads, and some of them only had a blood pressure systolic in the 150s and suffered strokes that, left them, somewhat with debilitation. So it's really, again, because it is the silent killer, something that, you just have to keep monitoring. And if you have hypertension, if your patients have hypertension, they need to, get back in for follow-up and, see their providers regularly. And self-measured blood pressure is a way to, make sure they're gauging that they continue to be in control even if they don't have a doctor's appointment for 6 months. So sort of a vague answer, but that's because that's how hypertension works for us.
Else have any other questions? All right, well, we'll give you 15 minutes back in your day. I will let you know that we will be sending out to everyone who joined us today an evaluation. We are going to be planning additional webinars in the future. We'd love to have your feedback about what topic areas you'd like for us to cover and what worked today and what we could have done differently. So thank you, everyone, for your time. Enjoy the rest of your day.
Thank you.
Yeah, I don't find that was extremely helpful. There were a couple of things that I didn't understand or know, Okay. Thanks so much for that.
Good afternoon.
You too. Meeting.
I'm going to end the meeting for all and save the recording.
Thank you.
Welcome.